Today I'm going to be speaking to you about exposure therapy. Exposure therapy is defined as any treatment that encourages the systematic confrontation of feared stimuli, which can be external, such as feared objects, activities, and situations, and internal, such as feared thoughts. The aim of exposure therapy is to reduce the person's feared reaction to the stimulus. The most common exposure therapies are in vivo exposure. This refers to a real-world confrontation of the feared stimuli, and as such, if a client had a fear of a dog, the client would approach the dog one step at a time until the client can pat the dog and have no anxiety. Next is imaginal exposure, where the patient is asked to vividly imagine and describe the feared stimulus, usually using present tense language and including details about external, such as sights, sounds, smells, and internal, thoughts, emotions, as cues. This is used when in vivo exposure is not feasible. It would be both difficult and hazardous for someone with combat-related PTSD to experience the right sounds and smells of combat in real life. In recent years, the advancement of technology, virtual reality exposure therapy, where patients are immersed in a virtual world that allows them to confront their feared stimuli, has been an alternative means to imaginal exposure, and preliminary data suggests that it can be quite effective. Most exposure therapists use a graded approach in which a mildly feared stimuli are targeted first, followed by the more strongly feared stimuli. The first step in this approach involves constructing an exposure hierarchy in which the feared stimuli are ranked according to their anticipated fear reaction. This is where the client and the clinician brainstorm as many feared external and internal stimuli as possible and then rate them in order of difficulty. The most common ranking method for this is the subjective units of distress scale, also known as the SUD scale, which assigns a numeric value of 0 to 100, with 0 being no anxiety at all and 100 being the highest level of fear, distress and anxiety the person feels. The next step is to conduct exposures in a gradual and systematic manner. Repeated use of the SUD scale will help track the patient's fear level as it increases and decreases. Typically, a higher item is not attempted until the patient's SUD level decreases significantly for a lower ranked item. Traditionally, higher level exposures are not attempted until the patient's fear subsides to the lower level exposure. By contrast, some therapies have used flooding, in which the most difficult stimuli are addressed from the beginning of treatment. In clinical practices, these approaches appear equally effective. However, most clients and clinicians choose a graded approach because of the personal comfort level and how this may affect the client's anxiety, as it could make matters worse. This form of therapy should only be attempted by professionally trained clinicians. Exposure-based therapies are highly effective for patients with anxiety disorders, to the extent that exposure should be considered a first-line, evidence-based treatment for such patients. In clinical practices, however, these treatments are underutilized, which highlights the need for additional dissemination and training. I hope this information will encourage clinicians to embrace exposure-based therapies for anxiety disorders as a viable and easily accessible treatment options. Thank you.